So good afternoon, everybody. Thank you so much for joining us for this third in the ABC series of ABC of Genomics. So my name's Helen Bethel. I'm a registered genetic counsellor by background, and I'm currently working in the Workforce Development and Education Lead job within NEY Genomic Medicine Service. So ABC of Genomics. So today we're going to think about clinical pathways and genomics. So our first session on Wednesday looks at the advances in genomics, so the technology that has driven the changes that we see today. Also, on Thursday, we did the basics of genomics, so that was just yesterday, and we looked at terms that we might use commonly in genomics, as well as the inheritance patterns that we often might see that people might recall in terms of their previous learning, maybe from GCSE or back at school. And then this session is pulling all of that together to think about clinical pathways and how we introduce genomics into that. So the hopes for tomorrow. So genomics has got many benefits. It can help to clarify diagnoses for patients, both in rare disease and in common conditions. It can help treat or advise treatments that are most effective for patients in acute settings or even longer term settings. And we can also use genomics to be able to predict adverse reactions from drugs before drugs are used. So moving away from that trial and error approach and moving to a more informed approach. We can also use genomics to be able to prevent, and I think this is where you really do get bang for your buck with genomics. So rather than just treating the patient in front of you, when a genetic diagnosis is made, it allows patients to be able to plan a family, so to take options to avoid having other affected children. It helps you to screen people who may yet not be affected. And it also gives patients who maybe are affected or are before they're effective options of active management. Finally, genomics also enables us to monitor disease, for example, cancer progression, and also in the spread of disease, of which we all became familiar with in the COVID epidemic. Ultimately, all of this means better outcomes for patients. So we know the power of genomics, and the question is how we harness that in a healthcare setting like the NHS. Well, the traditional model of genomics existed since the 1960s, was that when a diagnosis was made and red flags were picked up from that diagnosis, so a health condition or a health complaint was reported, and a clinician had a feeling from the family history or the presentation or the age or just a feeling of having seen this before. If there was a anticipation that there was some form of genetic relevance to their presentation, they would be referred through to clinical genetics. So all genetic testing in a traditional model had to be requested through clinical genetics. So families or individuals were referred through to clinical genetics in this model. They had their family history assessed, and if they were eligible for testing, then they were guided through that testing process. At the end of that process, at the end of that stage rather, the vast majority of people didn't get diagnoses. It's often rare that we're able to absolutely pinpoint a diagnosis, but for those where we did or indeed didn't identify a diagnosis, they would be referred back to their mainstream team for management. For those where a genetic diagnosis was picked up, they stayed under clinical genetics, as well as being referred back to mainstream for management. And under clinical genetics, we took them through cascade testing of informing relatives and helping to predict unaffected relatives. In a new, more mainstream model, so this is the vision of NHS England, we take out this step where the diagnostic testing is done by clinical genetics, and instead the diagnostic testing is done within those patient pathways in a mainstream setting. So again, patients where there might be red flags, where there might be family history or a certain presentation which is indicating an underlying genetic basis, those families, if they meet the testing criteria, rather than being referred through to clinical genetics for genetic testing, that can be accessed now by those specialties. The results can then be applied directly to decisions around treatment and management. Referrals to clinical genetics still happen, but these are more around the cascading of relatives and where a genetic diagnosis is confirmed. And also in a scenario where there's a negative result, there is often still an element where they still need to be referred to clinical genetics to have their family history assessed. But that happens at the end of the pathway, that kind of family history assessment, rather than having to do that if the patient meets criteria before they get their genetic diagnosis. So it helps to speed up the process and ultimately makes it more streamlined for the patient. There are examples of where mainstream is now successfully embedded both within certain specialties and throughout our region. For example, with breast cancer, so over the last decade or so, BRCA testing has gradually been moving over to breast care clinics, and now in the majority of the breast clinics that are offered across NEY, there is active engagement with clinical staff to take patients through that genetic testing when a diagnosis is made. This is particularly being driven because for some families, for some individuals, the information held within a genetic test can actually help guide access to certain types of treatment, because what we're learning more is that certain types of cancer with different genetic bases will respond differently to different treatments. In colorectal cancer, we have individuals where now it's standard that, and this is standard across the UK, that any diagnosis of bowel cancer, the tumour is tested under an MSI test, which stands for microsatellite instability, which is often a really good indicator of whether there's an underlying inherited tendency. So the MSI test is now carried out as standard. If an individual comes back with a positive result, so a high MSI result, they then, within a mainstream setting, are then taken through genetic testing to see whether that MSI high result is simply by chance, or whether it does actually originate from an underlying genetic diagnosis. At that point, the patient then might receive management advice regarding further screening beyond their treatment and surveillance from their diagnosis. And also, again, they would be referred to clinical genetics so that we can support families around that in terms of cascading that information to both affected and unaffected relatives and taking them through what we call predictive testing, where we're testing somebody unaffected. Another example is in cardiology, where we have inherited cardiac conditions. So, for example, with hypertrophic cardiomyopathy, there might be patients that are exhibiting symptoms either with or without a family history. And again, if they meet the criteria, then they can be taken through testing and access those screening options longer term, and also to give them advice about what the recurrence risk might be for any children that they may have, and also in terms of cascading information through to families, which again would be done through clinical genetics. So you can see that there are lots of applications for this, and I could go on and give more examples of mainstream. So it's not necessarily embedded in all services, but most specialties will now have pockets of where this mainstream is happening. Now, I've mentioned a few times about the criteria for what testing is. So what is absolutely key and underpins a lot of the mainstreaming agenda is the National Test Directory. So this is a document which is available online. You can see on the right-hand side the screenshot, which was taken just a couple of days ago, and it shows that the document was updated in July. It's updated every couple of times a year, so it is an ongoing process and it does change. So it is always worthwhile just double checking the criteria, because sometimes they do change ever so slightly. So the National Test Directory, which the website looks like the second image that has just shown up on the slide. The second document, the second link down, so where it says document, you can just see it peeking out to the behind here where it says rare. If you click on that, it's a PDF document, and that will give you a document that's about 300 pages long, but essentially it documents all of the genetic tests which are commissioned within the NHS. It standardises it. So before the test directory, there was a lot of inequity across the country in terms of local criteria for testing. Whereas because we are now centrally commissioned for these tests, it means that if it's on the test directory, then patients should be eligible for it, regardless of which part of England then they live in. This is only applicable to England, so the devolved nations have different criteria for testing, and they should be looked into separately. But certainly within England, this is the criteria. So the test directory, if we were to look within it, I've got some screenshots here to show you. And the example that I'm going to show you is of an inherited breast cancer and ovarian panel, so known as R208. So this is what the document looks like. This again is a screenshot of it. And all tests have got an R code number because that helps the lab to know exactly what test is being requested. So it's really key that you're clear in your referral to the lab what test you would like, because there may be other cancer panels for breast cancer or ovarian cancer, which might have different criteria and might cover different genes, so might not be the one that you're hoping to get. So it's really important that you take time to look at this and to make sure you label your referrals correctly. So for this one, the R208, what is key about the test directory, which I've mentioned already, is that it gives us the eligibility criteria for patients. So it takes you through exactly, if we look here, it tells us that anyone with a breast cancer under the age of 40 is eligible for this test. Alternatively, they might have bilateral breast cancer, and as long as they're under the age of 60, again, they're eligible for the test, and so on and so on. So it's sometimes important, if you look down here at criteria F, G and H, you will see that there are certain criteria about a Boadicea or a CAN risk, or it might well be about ancestry or even about family history. If that's the case and you're not sure, it's really important that we use confirmed family history, because often, particularly in cancer, Chinese whispers can play a very big part in what families understand about their history. So clinical genetics, again, are skilled in being able to assess these family histories to confirm this information. So if it is on the basis of a family history that you're testing, we would really encourage you to reach out to clinical genetics and liaise with them to ensure that this patient is definitely meeting the criteria. In some elements of the test directory, it will also tell you what genes are being included. Now, on this particular panel, for reasons unknown, it doesn't actually specify the actual genes that are being tested, but in other panels it does. What is also key on the test directory is this bit on the right-hand side of the screen where it says about requesting specialties. So it outlines which clinical services are able to request this test. So if you are a clinical member of staff and you sit within oncology or clinical genetics or surgery, then if you see a patient who meets again this criteria on the left-hand side, then you are then able to request this testing for that patient. So I've mentioned about approaches that are being rolled out and embedded, such as in oncology and in ICC. But I also just wanted to touch on more novel approaches. So as genomics unfolds and as it's brought out more and more on the NHS, it's still not completely clear where all of this will sit. So an example of a novel approach was a project that was carried out between 2023 to 2024, and this was in a condition known as familial hypercholesterolemia. So this particular condition, referred to as FH for short, causes high cholesterol and coronary heart disease, and it affects about 1 in 250 people. So it's anticipated that there are 240,000 people within Britain that are living with this, that have this condition. However, we recognise that it's massively undiagnosed. Because of the high cholesterol and the link to heart disease, treatment is obviously effective, and so we know that by diagnosing people and effectively identifying people with this condition, we can dramatically reduce the amount of heart disease and ultimately early mortality that is caused by the condition. As part of the NHS long-term plan, they stipulated that they wish to identify at least 25% of the FH patients in the UK in the next 5 years. And so one of the approaches was to look at using pharmacists in order to be able to extend the amount of testing that is offered on the NHS. So the project formed three parts. The first was to upskill pharmacists to offer testing, and that was a project done in collaboration with Northumbria University. There was secondly a record search of GP records to see if they could identify candidates with repeated high cholesterols with unexplained reasons for that. And then finally, there was a project to marry those two together so that pharmacists were able to identify those patients and were able to contact them and offer them the option of going through genetic testing. So this project isn't yet commissioned, but it was hugely successful and obviously demonstrates an approach that is slightly novel. So you wouldn't necessarily think of pharmacists as carrying out genetic testing, but it's been shown that it can be done hugely successfully. So in all of this, where is the genomic medicine service? So where is clinical genetics? It is still very much there. We are still a small specialty, but our role is very much to support clinicians that are taking patients through mainstream, to take part in MDTs, to discuss those patients where they might not quite fit the criteria and help support whether they should or shouldn't go through testing. And ultimately, our main role, I've already mentioned today, is very much in that cascade testing. So I've put a picture on the slide of a droplet in a pond, and this is often a good way to think about clinical genetics. So essentially, the patient is that drop in the middle where a diagnosis has been made. And in a traditional diagnosis where there isn't genetic factors, you would just deal with that droplet. Whereas in genetics, what is different is that those drops cause ripples, and those ripples are relatives who are then known to be at risk of inheriting and therefore likely to be eligible for some form of screening or active management. And so in mainstream practice, you are dealing with the drop, but it is the ripples that the genomic medicine service will still be there to support. So we're not asking you to go out and start dealing with relatives and a lot of the ethical issues that might come with cascading that information or not to relatives. You know, that is where clinical genetics still does have expert skills and is still there to be drawn upon. So I just wanted to touch on, last of all, the clinical pathway approach. So how do you take this amazing bit of science? How do you take a strategy like accelerating the genome, and how do you upskill a whole NHS workforce to be able to embed this amazing science into clinical pathways which are already busy and stretched? Well, the Clinical Pathway Initiative, or the CPI, was an approach that was designed by the Genomics Education Programme team and has been picked up by NHS England's Genomics unit with a view to using this as the model for how we upskill our workforce. Essentially, they're relatively simple. You plan out or you map out your clinical pathways. At each step of those pathways, you align competencies to them, and then you identify the education that you would need to meet those competencies at each step in that pathway. I just want to show you an example of CPI, which is for Lynch syndrome and has just been released. And you can, I think I put a QR code on the slide to come. If I haven't, then I will put a link in the chat shortly. So Lynch syndrome is that inherited tendency, one of the inherited tendencies to bowel cancer that I was mentioning before. And this CPI essentially has mapped the pathway into 4 components. Firstly, there is the pathway for a pretest, so a patient who has been received a diagnosis and is going to be taken through genetic testing. The second in pink is the post-test pathway when a genetic cause for the cancer has been found. The third pathway in this yellowy mustard colour is when no change has been found at that point in time. And the third one in green is when there's been an uncertain result found. On the website, if you click any of these boxes, and if for the moment we click this one on the left, this is what it would bring up. So this is the pre-test pathway, which has been broken into different steps. And the first step is that you determine the patient eligibility for testing. So on the right hand side in blue boxes are the competencies which are needed in order to be able to successfully carry out that part of the pathway. And by clicking on each of those boxes, you get a drop down list, which is the resources that you can use in order to meet that competency. There have currently been 2 CPIs that have been published, one in familial hypercholesterolemia, which is the condition that we've just been talking about in that novel approach to mainstreaming, and also in Lynch syndrome. There are, however, 25 paths in development, and so we're fully aware that in the next few months, it's highly likely that these will come thick and fast to being uploaded. If you'd like to take a look at the clinical pathways, I did think I'd put a QR code in, and sure enough, you can see one on the screen now. There's a QR code which will take you directly to the CPI website. So is genomics on your to-do list? So do you know that genomics is something that you should be looking towards to upskilling within your specialty, within your department, and is it on your to-do list? Well, if it is, there's 2 things that you can do. You can access and use one of the CPIs that have been published. So as I say, if you look, there is 2 already. On the website, there is also a list of CPIs that are being developed. So you might choose to actually, if there's one in your specialty that covers your particular area of work, it might be that you want to reach out to the authors of that pathway, of that CPI development, to be involved in that process. Alternatively, there may be no CPI that meets your specialty or your requirements for your pathway, and so it may be something that you feel motivated after today to develop, and in which case I would really encourage you to reach out to your local GMSA, your local genomic medicine service. So just to summarise, what do you need to know? So you need to know what the benefits of genomics are for patients. You need to understand the basic concepts. And you need to know how to access the test directory and also understand the CPI approach, which is being taken to upskill staff. What you don't need to know is complex genes names, complex patterns of inheritance, how to cascade information to relatives, and how to test unaffected relatives. This is simply an extension to your diagnostic toolkit, and it doesn't need to be over complex. So if you've enjoyed this or any of the other series that we've done this week, then you might choose to engage with us either by signing up to our newsletter with the top QR code at the top, or following us on any of our social media channels. You might decide to watch the other ABC series, which again will be available in the next coming weeks on our website, or you might even want to take a look at the Lunch and Learn series, both past and upcoming events, again that is on our website, because we've got some fantastic resources on there. Finally, I just want to mention GNotes, which is a just-in-time resource of genomic notes for clinicians. There are 2 parts to this resource. It's hosted on the Genomics Education website. And essentially the 2 parts, the first is an encyclopedia of knowledge. So every term relevant to genomics that you can think of is on there. And then the second part is a clinical resource, which is written in chapters for clinical specialties. Finally, if you fancy any formal learning, again, I would encourage you to take a look at the Genomics Education website. So just to finish, we are doing an evaluation of this series because it really helps us to understand what you have and haven't found helpful as part of this. We've also linked it in with certificate of attendances, so if you could fill the form out, it literally takes 2 minutes, no more. If you fill it out then and give us your details, then we can send you a certificate of attendance.